So now proceeding further, I would request Dr. Hina ma'am to introduce our next speaker.
So this is the most beautiful moment of my life right now, because I am going to introduce my boss, my guru, my teacher, Dr. Vijay Panikar. We don't need words to introduce such a grand man I have met in my life, because he is my teacher, and I got to know him through as being a teacher. What a wonderful human being he is. Just for a formality, I would go with the qualifications he has. He's MD, DNB, FCPS medicine. He works as a consultant diabetologist in Leelavati Hospital and Research Center, Mumbai. His area of interest is endocrinology and diabetology. I will be always grateful to my sir. Over to you, sir. Panikar sir.
It is indeed a pleasure to be with SwasthyaCON here today, and thanks for the invite to the organizers. The topic given to me is Remogliflozin, the Indian real-world evidence. SGLT2 inhibitors across all guidelines have steadily gone up the ladder of recommendation that we should start SGLT2 as early as possible in all type 2 diabetics. If you see the evolution of the recommendations, in 2015 it was only for glycemic control. In 2016, when it was demonstrated that SGLT2s have cardiovascular benefits, it was being recommended for cardiovascular benefits. In 2018, atherosclerotic cardiovascular disease and chronic heart failure were recommended as agents, proven benefit on MACE and CV deaths. In 2019, studies on nephroprotection came. So again, nephroprotection in type 2 diabetes plus CKD plus diabetic kidney disease were included. And in 2020, you have the final thing happening, that HbA1c, yes, but atherosclerotic cardiovascular disease, heart failure and CKD are also become indications, and it has gone up the hierarchy. This is the European Society of Cardiology, which for the first time had said, we always talk of metformin as the first drug. But here the Cardiological Society suggested that if the patient already has atherosclerotic cardiovascular disease or a very high risk for cardiovascular disease, you could start SGLT2 inhibitor or a GLP-1 as a monotherapy even before metformin. And if the patient is already on metformin, obviously then the choice again boils down to an SGLT2 or a GLP-1. The 2020 ADA ESD consensus statement, SGLT2 inhibitor is the preferred OHA in type 2 diabetes mellitus patients with atherosclerotic cardiovascular disease and chronic kidney disease. This is a new algorithm which again prioritizes the SGLT2 inhibitors. If in type 2 diabetes, if A1C is above 7 on patient on metformin, there is evidence of heart failure. SGLT2 inhibitor is the drug of choice. If patient has heart failure or atherosclerotic cardiovascular disease, again SGLT2 is the drug of choice. But if they have only atherosclerotic cardiovascular disease, and if they have a stroke or TIA, then pioglitazone, GLP-1 would be the drug of choice here. And in coronary artery disease, again, SGLT2 inhibitors and GLP-1. This is a new algorithm, and this is looking at the risk factors in type 2 diabetes and treating accordingly. In the early days, when I say maybe 5 or 10 years ago, only glycemic control was the target. Your target was to get it below HbA1c below 7. But now things are changing. We are looking at comorbidities and treating accordingly. If you look at the approval journey of an SGLT2, right from 2013, canagliflozin, DAPA, EMPA, erythrogliflozin, and then finally remogliflozin was approved in India in 2019. Now, clinical development and the real-world utilization of remogliflozin. See, basically, all the glyphosins are derivative of the fluorescins. But fluorescein could not be developed as a drug. but it served as a prototype for the development of the O and C glycoside molecule, which improved stability and SGLT2 activity. So you have basically two types of SGLT2 inhibitors, the one with the O glucoside, which is your remogliflozin and sergliflozin, and the C glycoside, which is CANA, DAPA, EMPA, and L2. Now, if you look at all the SGLT2 molecules, all the SGLT2 inhibitors interact with the receptor because they have an absolute molecular resemblance to glucose. Now, each of these molecules have two components. One is the glucon or the sugar part, and the aglucon, which is the non-sugar part. And that glucon part in all SGLT2 inhibitors is a glucose molecule. It fits perfectly. So that is where, if you look at all the SGLT2 inhibitors, the receptor binding site is a glucose molecule. So the efficacy and the equivalent inhibition, pharmacodynamic inhibition of all SGLT2s are similar. Now we come to the difference in the pharmacokinetics due to susceptibility of beta glucosidase enzyme. All the O glucosides have O glucosidic bond that is lysed by beta glucosidase and hence have a shorter half-life. Whereas the C glycoside, by molecular remodeling of the O glucoside bond, gives it a longer half-life. So when you look at DAPA, CANA, EMPA, they have a once a day dosage. The Remo has a twice a day dosage because of shorter half-life. This is just to look at the steady state plasma concentration of Remo. It's basically every 12 hours. So you need to have a BD dosage with remogliflozin. With the advent of Remo in the market, the new kid on the block, the sales of Remo have really shot up across India. Now there is a robust clinical development program for Remo. Early 2007 was just a development study for Indian patients. And now there are many studies which are in the pipeline from 2019-20 continuing clinical development, your Revolution, Inspire, Remit, Adopt, and HF, Remit studies. Now, all these had a spanner in the works because of the COVID, but I think they will again pick up very soon. There has been a lot of evidence published in international journals about remogliflozin, and these are the evolving evidence. These are the different studies which are ongoing with remogliflozin. When you talk of Revolution, this is going to be a massive study over 100 sites all over India, and it is DGCI approved study. Remit heart failure, again looking at the study in type 2 diabetes with reduced ejection fraction heart failure, 10 sites across India, study is in progression. Remit GV is to look at glycemic variability. Adopt is Asian diabetes outcome prevention study. Type 2 diabetes patient with no cardiovascular disease, look at the outcomes, 2-year duration study. So these are the timelines which are there. Remo plus Vilda, Remo plus Tenali, Remo plus Vilda has already been launched in the market now. Then we have the Inspire study, which is the real world study. There were about 28,000 patients in the whole cohort. But in the final analysis, they have taken 5,452 patients who had all the parameters that were there. Others had incomplete data, so they were rejected. Glycemic assessment, we looked at HbA1c, fasting, postprandial, metabolic assessment, blood pressure, and hematological assessment. Now, when you look at HbA1c in this real world study, at 3 months, there is a decrease of HbA1c of about 0.95. You look at the fasting glucose, it reduces by about 42 milligrams. The postprandial glucose by 69 milligrams. When you look at the body weight at 3 months reduced by 2.6 kilograms, and this is all in keeping with all the other SGLT2 molecules. It matches. And the BMI reduced by 1, which is again like you see in the other SGLT2 molecules. Blood pressure reduction 3.3 millimeters, again very comparable. The diastolic BP by 2.3 millimeters. And if you look at the equivalent efficacy observed from different real world evidence for SGLT2, whether it is a DAPA, CANA, EMPA, or REMO, they are all comparable. zero point 0.9 to 1 is the reduction of HbA1c at 3 months. Now, this is a real world data from our center, where we have seen about 3,294 patients. And if you look at the time frame, 1 month is 2,800, mean with 3 months follow up, 2,200, 6 months follow up, 1,900. And what did we find? The fasting glucose at 1 month comes down by 52, 2 months by 53, 3 months is almost 50. So around 50 milligram is what the fasting blood glucose came down in our study. The postprandial glucose again 50 to 60 milligrams, 58 to 60 milligrams per deciliter is what comes down. The HbA1c reduced by at 3 months was 0.65 and at 4 to 6 months was about 1.2. So there is a significant reduction of HbA1c, and I'll tell you this is comparable to all the other SGLT2 molecules. The body weight at 1 month came down by 0.68, at 2 months came down by 1.23, and at 6 months by 1.48. The serum creatinine showed a mild elevation, and this is again in keeping with all the other SGLT2 molecules. The EGFR, with all the SGLT2 molecules, initially when you initiate a SGLT2 molecule, you will find that the EGFR goes down, but then it steadies and it remains good and improves. Whereas a patient not on an SGLT2, you will see the EGFR going down steadily year on year. Talking about the side effects, the commonest side effects are genitourinary fungal infection. About 3% females develop vaginitis. Almost 3% males also develop vaginitis. UTI, polyuria, mycotic infection, loose motions, discomfort. These were some of the other causes. I mean, there were almost 11 patients where we had to discontinue the treatment because of persistent polyuria. Mycotic infections, loose motions. One patient had severe loose motion, and it was definitely because of Remo. Because we stopped Remo, his loose motion goes away. We reintroduce Remo, and it comes back with a bang. Then we did a subset analysis of 50 milligrams BID, the standard dose being 100 milligram BID. But we looked at 50 milligram BID, and we had a significant number of patients there. And what did we find? That the HbA1c reduction with 50 milligram BID at 3 months was 1.16 and 1.27 at 4 to 6 months, which was comparable to the 100 milligram BID. Fasting sugar came down by 30 to 35, whereas with 100 it came down to almost 40, 45. Postprandial sugars 55 to almost 60, whereas with 100 milligram, you had at 3 months almost 74 milligrams of postprandial sugars coming down. But they were comparable. BID dose, total body weight, 1.1 at the end of 6 months, whereas 3.28 at the end of 6 months with 100 milligrams BD. So basically, if you really look at the difference, 50 milligram BD was good for glycemic control, almost matching 100 milligram. But when it came to weight loss, 100 milligram somehow seems to be more potent than 50 milligram BID. Change in EGFR, like I said, it comes down and then goes up. This is comparable for both the doses. Serum creatinine, very similar findings. So When you look at this subset and you look at Remo as a whole, Remogliflozin 100 milligram was prescribed to patients with significantly higher fasting and total body weight. Both the doses have shown to provide clinically significant reduction in their respective subsets. It has been well tolerated by the patient with no major safety concerns identified. And to conclude, Remogliflozin in the real world setting has shown a clinically significant reduction in HbA1c, fasting, and postprandial glucose, plus significant weight reduction. The clinical efficacy is seen early in patients, just like any other SGLT2. It is being well tolerated with no major safety concerns identified, again, very similar to the other SGLT2s, except the price. The clinical response is at par with other SGLT2s currently available in the market. This is what is the current position of Remo. It is a good molecule with a good SGLT2 inhibitor effect, which is comparable with all the other SGLT2s which are available in the market. Thank you very much, ladies and gentlemen, for a very patient hearing. Thank you.
Thank you so much, sir, for this session.